Good afternoon. I will start with a little introduction and then go to some problems, but I'm going to discuss discharge and moreover the delay in discharge. I, like Keith told you, was involved in the Enhanced Recovery Program since the beginning in 2001. I wrote my thesis and finished it in 2009, and then I got an implementation fellowship from the Netherlands Organization for Health Research and Development. I got an intensive educational program at the Institute for Quality of Care in Nijmegen, so I was teaching implementation issues. I know I have an advisory role in implementation and also in implementation research. I'm doing about 10 to 15 implementation projects in the hospital, and in two of them still the ERAS I'm involved in some ERAS issues. One is the long-term evaluation of the breakthrough project, and the other one is ERAS in gynecology. We did a pilot in Maastricht. It was very successful. I would suggest to start in gynecology surgery because it's much easier than in colorectal surgery. But the most important reason that patients are on average 55 years old with less comorbidities and easier to mobilize and to enhance recovery. Well, this is the order of this one. I work in the University Hospital in Maastricht. It's the smallest hospital in the Netherlands. It's about 700 beds with 30,000 admissions a year, and we only have 22 theaters and perform 150 colorectal elective procedures a year. It's a very small hospital. I need to change this. It's a small hospital, but we were small but tough. We got 2 surgeons involved in the Enhanced Recovery Group. You see in this slide. I think this is Keith, or isn't it? And Martin is somewhere in the background, I think. We started in 2001 with the implementation of the program in Maastricht. And from 2006 till 2009, we were involved from Maastricht as experts in the breakthrough series perioperative care. This involved, in this breakthrough project, 33 hospitals participated all over in the Netherlands. And at the moment we are studying the long-term effectiveness of this program. And there is a poster from Stephanie Ament, the PhD researcher on this project, who shows some preliminary results, what we achieved on the long term. The ultimate aim of the Enhanced Recovery Program is to enhance recovery, to allow patients to recover more quickly from major surgery, and thus consequently reduce the length of hospitalization. And that is exactly what happens if you successfully implement the program. Your recovery, that are the orange box, your recovery will reduce with 3 days, and so will the length of hospitalization. These are the results of the 33 hospitals in the Netherlands that implemented the program. The best performing hospital achieved a length of stay of 4 days, and none of us of the 33 hospitals achieved what Kiele did in Copenhagen. But I'm going to discuss the blue boxes. That's what we call delay in discharge. Delay in discharge, we call when a patient is, we speak of a delay in discharge when a patient is functionally recovered, is fit to go home, but still occupies a hospital bed. And it was possible to measure whether there was a delay in discharge, because from the beginning on, the Enhanced Recovery Group defined when a patient, 3 criteria to judge whether a patient was home ready or not. A patient should tolerate food, should have pain control on only oral analgesics, and should be mobilized to preoperative level, and then he's fit to go home. One of the first things we measured was that in all of the 5, except for Copenhagen, but all the 4 hospitals of the ERAS group, that we all had a delay of discharge. And we thought that maybe these discharge criteria were not really measuring the home readiness. So we did a little evaluation of every patient that was that enrolled the ERAS program, and we evaluated whether he was really ready to go home on the day the discharge criteria were met. 150 patients were evaluated, and 82% of the patients had no reason to stay in hospital after meeting the criteria. 10% of patients stayed for post-surgical observation. They had diarrhea or bowel distension or fever, so they stayed a couple of days for observation. We had 3% of patients remaining in hospital because of a wound infection. It was very remarkable that before the ERAS we had a 50% of patients delay because of a wound infection, and afterwards we had only 3% of patients with a wound infection. But it was not a decrease in wound infections, but the wound infections occurred at home because the length of stay decreased with several days. When these wound infections delays discharge with a median of 2 days. And it's very remarkable because the wound infections that occur at home are treated in the outpatient setting, and home care is arranged at the same day. And actually 5% of patients have other medical complications that keep them in hospital if they fulfill the discharge criteria. So we concluded actually that when a patient is functionally recovered according to this criteria, is really fit to go home. And this slide is the evaluation of the first 425 patients that were entered in the database, and shows that the inability to send patients home on day of recovery is strongly associated with a prolonged length of stay. This is one of the most important slides I have to show you today, because these are the 10 best performing hospitals in the Breakthrough project who implemented the program very well. We have compliance rates above, on average above 80%. And then it shows you that the variation in length of stay is primarily determined by your organization of discharge. The need to stay in hospital is quite similar in all hospitals, it's 3 days. But the length of stay varies from 7 to 4 days. And this is pure the organization of discharge. I've discussed this with several surgeons all over the country, this delayed discharge. This is what they tell them, zolang someone het liggen en erin doe je vallen. That's what they say in the Netherlands, but it's translated. We don't care how long a patient stays in hospital, as long as we don't have leakages and there are no death. So actually, I'm here to express my frustrations in 4 propositions, and I want you to put your hands in the air if you fully agree with my propositions. The first one is that enhancing recovery is not worth the effort if we let patients stay in a hospital for another 4 days after he achieved recovery. We were discussing it several times in the meeting with the nurses. For God's sake, why are we forcing mobilization on day of surgery? Why are we forcing mobilization? Why have patients to stay out of bed for 6 hours the day after surgery, be recovered on day 3, and then we let them 4 days needless in hospital? So, I think if you don't send patients home when they're recovered, if you don't do that, the enhanced recovery program is not worth the effort. Who agrees? Thank you. My second proposition. If I would undergo a colorectal resection, I would leave as soon as possible, even with the epidural inserted. Kristen Fossland from Tromsø told me that I don't understand. If being a healthcare worker, my delay in discharge would be -1. Who agrees? Nobody? You would stay 3-4 days for nothing? Okay. Who agrees? East, west, home, west? Okay. And my last proposition is, wat jij niet wilt dat u geschiet, doe dat ook een ander niet. It's translated, do as you would be done by. I think you all agree with this one. When I prepared my presentation, I was Googling for some pictures of patients, pictures of delay of discharge from hospital, and I found a lot of pictures like this. People were very glad that they go home. And I think that this one is a healthcare worker, don't you think? These are pictures of people who go home. And we know that being home increases the autonomy of patients and increases the quality of life. But we also know that especially for older people, in hospital is not a good place to be because they institutionalize very quickly, and also the risk on hospital-acquired infections increases with a prolonged stay. There are also some economic considerations of if we let people stay in hospital needless. There's an efficiency problem, I think, and efficiency is one of the 6 domains defined in the quality of care. A good quality of care does not only mean that the care is safe and that it's effective and that it's patient-centered, but also means that we don't waste equipment, we don't waste supplies, energy and IDs, so that we are efficient. Letting people stay for another 3-4 days in hospital needless is quite a problem, I think. And then when we would send patients home, beds will be empty, and we will save money if we leave it empty, or we will spend some these resources on other patients. I will give some recommendations of how to improve this, how to reduce this delay in discharge. And I have three advices as an implantation scientist. First, you have to realize that changes do not implement themselves, but they need a comprehensive approach. The second recommendation, the second state of the art, is actually that there are no magic bullets. There is not one intervention that works wherever you are. It may be that various interventions are necessary at various levels. We have no easy solution for the implementation problem. And the third state of the art is that there's a broad consensus at this moment on the value of tailoring your intervention to the local determinants of practice, to the local barriers and incentives. The first one was that changes do not implement themselves. This was very clearly demonstrated by Ioannidis in 2004. He studied 100 studies. He studied the long-term effect of 100 studies published in scientific journals, and found that only one of the 100 studies had actually influenced daily care. But there always are examples that are uitzonderingen. Exceptions. There are always exceptions that dictate the rules. This is one example that you find in every implementation book, and that illustrates that sometimes it's very easy to change practice. This is the acute otitis in children with the surgical incision that was the standard of practice in the 80s. And the publication that watchful waiting is as effective as a surgical incision resulted in a total abolishment of the surgical incision in children almost all over the world. But that is one of the few examples we have of practice that changed after publication in the journal. Most of the time we need a comprehensive approach, and there are several models for improvement. The IHI has its own model of improvement, and the NHS had a very nice one, I think. It's on its sites. It's a paper how to improve with a lot of practical advices. In the Netherlands, we use the model of role advancing, and that's a very easy model because it's very similar to clinical decision making. It says that you should make a diagnosis, then decide to do an intervention, and finally you should evaluate what you're doing. I think the most important part for us as implementations, from the view of implementation science, is the diagnostic analysis. This is a part of an improvement projects, and I see it a lot of times in the clinic. If we start an improvement, we go right to action. We start with a lot of activities, employ a lot of activities, but it's extremely important that you know exactly what your current practice is, who is involved, to what extent it deviates from your intended care, and moreover, what your barriers and your facilitators are. Because an intervention that is not focused on the barriers that will happen will be very ineffective. There are a lot of interventions that you might employ, but for example, if your problem is that the nurses have no time to mobilize in the night shift, you can educate whatever you want, that won't solve the problem. So the most important, if you start any improvement activities, that you know exactly what your intended care is and what the problems are going to be, and your interventions should be totally focused on that problems. It's so logical, but mostly we just start implementing and start with education, with some standard measurements to change practice, but it won't be effective if we not tackle the problem that underlies what is necessary to change. Barriers. I thought I will discuss some barriers that were mentioned, why we had a delay in discharge in the Netherlands or in Maastricht in the hospital. We found barriers in delay of discharge that were on several levels. It were on the patient level, on the nurses level, but also on the surgeon's level. We had patients who don't want to go home, who want to be cured for no matter how long it takes because I have cancer. We had patients who said, I paid 40 years for my health insurance, so now I'm going to take it. And there are sometimes patients say it's better here in the hospital than at home. I think if this the problem is at patient level, you should educate, for instance, patients that being in a hospital or being home, and you should translate that, educate patients that being home increases their autonomy, and that will result in more positive lifestyle events and will result in an earlier possibility to go to social events, or that they earlier will do the hobbies if they increase their autonomy at home. But you should focus your intervention to the problem you have. We have at the nurses level, sometimes, especially in the beginning, we had a problem and nurses didn't believe that patients were doing well at home. They feel compassion with patients sending home after 3 or 4 days after surgery. And the problem was that I was the facilitator, so I phoned the patients at home, I did the checkup, And I noticed that patients were going shopping, and they were going to the birthday of the grandson, and they were doing all the things, and feel very comfortable with the early discharge. It was very difficult to explain it to the nurses. So if this is a problem, it might be a solution that the nurses do the telephone checks themselves, phone their own patient, ask them how they're doing, and get convinced that an early discharge would be would give no problems at home. And the last thing is that one of the most major problems, the major problem we have is that the surgeons still are, from a traditional view, still think length of stay is not an important outcome measure. It's we now studying the long-term effects in the 10 best performing hospitals in the Netherlands of the breakthrough, and 8 of the 10 hospitals had no idea when the lengths of stay were. They knew exactly how much anastomotic leakage they had every year and for every surgeon, but they had no idea that the length of stay raised again with 2 or 3 days. It's a huge problem, I think. It's not easy to tackle, but we know at that level that education of surgeon should be is not the option. I think it's very important that you have a respected peer like Henry Keelet or like Keys or a local opinion leader to get them on board, and he's the role model that will be followed, and it's very important to look for interventions to tackle that problem. My message for today is that we have a problem, that needless hospital stay in ERAS patients should be reduced, and that it's very important that you analyze your current organization of discharge before you select any improvement activities that are specific for your local situation and that you might enjoy working on improvement. And this is a quote from Don Abedian that's often used in implementation presentations. If we are really committed to quality, almost every mechanism will work. And if we are not, the most elegant constructed mechanisms will fail. Thank you.